Hi everyone, I am Dr. D Sreenivasa, Senior Gastroenterologist from Bangalore Institute of Digestive Sciences at Bengaluru. Today I am going to talk a little about dyspepsia. Dyspepsia is a vague term. It actually means either discomfort or pain in the upper abdomen, usually in the center or the right side of the abdomen under the rib cage. What is the incidence? It is very common in the Western population. It's about 10 to 20% of the population, whereas in India, in different regions, it varies from 40 to 50%. So you can imagine the number of persons or patients who suffer with these symptoms. One important thing about dyspepsia is it's got a wide differential diagnosis. Not everything which has got a discomfort in the upper abdomen is dyspepsia. There are a lot of other causes. Sometimes you have organic causes like ulcer disease, gallstone disease, heart disease like ischemic heart disease, which can present with discomfort in the upper abdomen. So please do not neglect thinking any discomfort in the upper abdomen is dyspepsia. Let us try to understand how to diagnose dyspepsia. There are two types of dyspepsias. One is called as functional dyspepsia and second thing is organic dyspepsia. Functional dyspepsia means there is no structural problem in the upper intestines, that is either in the food pipe or the stomach. So that's why it's called as functional dyspepsia. There are two main variants. One is called as epigastric pain syndrome and the second one is called as postprandial distress syndrome. When do we diagnose these entities? By definition, if it is postprandial distress syndrome, there has to be easy satiety. That means you know how much quantity you eat normally, which produces sort of sense of satiety. But if the quantity goes down, or you eat only half of what you eaten and you feel fully satisfied or you're full, then that is called early satiety. Second thing is there could be extreme discomfort in the upper abdomen after eating. These are the two main things. Is it 1 week is enough? No. The definition says the symptom onset has to be at least 6 months ago and the symptom should have been there for 3 months. So you cannot say 1 week discomfort in the abdomen as functional dyspepsia. It has to be at least of 6 months duration and with symptoms being persistent for the last 3 months. There are other things which you should not consider as part of postprandial distress syndrome. If there is a heartburn, if there is vomiting, if there is some bleeding from the intestinal tract, this is not functional dyspepsia. Reflux disease, that's GERD itself, is a different issue and that is not part of the epigastric pain syndrome or the postprandial distress syndrome. And before we label it as functional dyspepsia, either postprandial distress syndrome, we should know that there is no structural problem. If there is a structural problem like narrowing of the intestine, the area which of the stomach which joins the intestine, that is a pylorus, that can also produce sense of fullness and easy satiety. That has to be ruled out by an upper GI endoscopy. It is not necessary to do upper GI endoscopy for all functional dyspepsia or postprandial distress syndrome patients. When do we decide to do that? If there is evidence of bleeding inside, like in the form of black stools, dark color stools, there is a significant weight loss, or there is a persistent vomiting. Persistent vomiting is not a feature of this dyspepsia symptoms. The second subcategory of this functional dyspepsia is what is called as epigastric pain syndrome. As the term itself indicates, epigastric is the area in the stomach which is above the navel or the umbilicus. So in the center of the abdomen, the term epigastric pain syndrome means there is a pain in the upper abdomen, especially in the center of the abdomen. The upper central abdomen is called as epigastrium in medical terms. This pain can be recurrent and again it can be something like a burning type, or it can be just a discomfort. The pain may or may not be related to food intake. The duration of the pain should be about 6 months before we diagnose it as epigastric pain syndrome. And another thing is, it has to be, the symptoms have to be present for at least 3 months. One common mistake many people, including some physicians, make is misinterpreting every pain in the upper abdomen as epigastric pain syndrome or functional dyspepsia. there are two important causes which need to be considered here. One is a gallstone disease, which has got a typical symptoms you get pain in the center of the abdomen, usually brought on by fatty food, lasts for about 30 minutes upwards, should not be equated to any epigastric pain syndrome. Second is a heart disease, especially when there is a reduced blood circulation to the heart, it's called as ischemic heart disease, especially inferior wall ischemia also produces pain. So these two should not be mistaken as epigastric pain syndrome. Other GI causes like peptic ulcer disease also produces pain in the upper abdomen, but it's got a typical characteristics relieved with food. There could be nocturnal pain. There is something called as periodicity where the pain keeps coming and going. Upper GI endoscopy is diagnostic for ulcer disease. Before we diagnose it as functional dyspepsia, as we mentioned earlier, organic dyspepsia has to be ruled out. So are there any subcategories of patients who require thorough investigations? If one is above the age of 50, if there is weight loss, if there is decreased appetite, if there is evidence of bleeding in the form of dark black stools, then one definitely requires further investigations, including upper GI endoscopy. Coming to causes, why does this functional dyspepsia occur? Functional dyspepsia occurs because of multiple reasons. One is there could be some issue with the movement of the stomach, which could be again some fault or malfunctioning of the nerves which supply the stomach from the brain. Second thing is something called as visceral hypersensitivity. What is visceral hypersensitivity? That means stomach is extremely sensitive to stimuli. So normal stimulus is perceived as obnoxious symbol. The third thing is sometimes it could be because of Helicobacter pylori infection. Sometimes it's also because of certain intake of drugs which we miss in taking history, especially Ayurvedic and homeopathic medications. So these are the various mechanisms why functional dyspepsia happens.